So the next speaker showed up at the MGMA conference in San Francisco a couple of years ago and got super inspired about direct care and direct primary care and ran back to her very large fee-for-service practice and started to come up with a plan to how do we transition to this model. And so I'm really excited to hear from Lori-Ann Martell today about all the work she's been doing over the last couple of years to set her large group practice up for success in their launch of their direct care operation. So please welcome Lori-Ann.
I just said I feel so weird up here speaking after following one physician after the other, but I guess I'm the other half of the equation. My history is I'm a nurse by trade, became a manager because I wanted to elicit change in our organization, and slowly I've evolved into a practice administrator. I started with 2 doctors and 6 staff. I'm currently at 9 physicians and 64 staff members. So we have a very large fee-for-service practice. We've been in business for 21 of those years I've been there. So I feel like I am very much like the physicians and the other people in this area that I don't want to do this anymore. I'm burned out, I'm tired, I am exhausted with rules and regulations. And so I decided after MGMA, the week before I went through to MGMA, I was on an elevator going down the 5 stories out of my practice, and I was on an elevator with a woman who was crying. And she wasn't crying because she was diagnosed with anything bad. She was crying because she was relieved that she didn't have anything wrong with her. And it took her 6 months to save up the money in order to pay for the physical that we were charging her at 175% of Medicare. And that's when I decided I needed to do something. So we are slowly progressing to changing from a fee-for-service business to a direct primary care. If it wasn't for the hurricane, we would probably be live by now. So the steps that I have taken over the last couple of years have been slow, but I haven't given up. And it's as much as changing my culture as it is changing the mindset of the people that I work with. Because I feel like we're very ingrained with regulation and rules because that's what's been running us for so long that it's really hard to think of doing anything different for any other reason. So at this point, these are the steps that I've taken. I identified our concerns. I listened to the staff. I tried to realize what the core basis was of the major dysfunction in our organization and what was costing us the most money. We evaluated the root problem. I analyzed how it affected us, identified what is measurable, because you can't really lie about numbers, so I think it always goes back to numbers. We identified staff that are forward thinkers and people who could open up to change and people who are more tech savvy because we really feel like that's where we need to be in order to be successful. And then, if we go to DPC, how is that going to solve some of the issues that we're seeing in our clinical area, in our clerical area, in our lab, and in our environment generally? And also, how is it going to improve the quality of everybody's life in our organization, not just our physicians? So where we are today, we're 32 years in practice. We're the largest privately owned practice in our county. We have 9 full-time providers. We're 7 days a week, 12 hours a day. We are a primary care appointment-driven practice with an occupational and urgent care overlay. So we have an interesting mix that is absolutely perfect for DPC in that we're already recognized as leaders in medical care and controlling cost and improving quality in a model that was designed by a large employer group that Blue Cross Blue Shield rules, and we're able to kick the butt of any other group in town as far as quality and containing cost. We're non-par with Medicare and Medicaid. We never have. We actually never contracted with Blue until 7 years ago, almost the biggest mistake of our lives. But financially, we had to do it because we had too many patients walking out to seek other providers. But my goal is to be successful with DPC, to kind of put it in the face, mostly of Blue Cross Blue Shield because they make my life so miserable, and to prove to everyone in our community that we can do it better if we're given the option to do things the right way. So we already are the largest provider of employer services in our community, and I'm at the table for key decision makers in our community regarding their benefits, their occupational. I love mod factors. We do a lot of workers' compensation, so we're very well vested in this area. Again, a great reason to move. So we are a cog in the wheel of fee-for-service. As you can see, we do 32,000 visits a year, which is about 100 visits a day. We are 7 days a week. We have an average of 3.5 providers on any given day. I don't sleep much. Haven't slept for a while. But we have always steadfast refused to participate in MAPS, MIPS, MACRA, any of the standardized reporting. No matter what I look and where I look, I see no data that proves to me that that's going to help me in quality of my patients or help my providers in any way, shape, or form. My providers are aging out. My guys are getting older. I'm having a harder time recruiting younger doctors because it's quality of life. We have quality of life. We're a 7-day, but they don't work more than 2 days in a row. They don't take call and they don't round. People don't even want to work 12s anymore. So we're having a hard time recruiting. It's the stress level of our physician, but it's also the stress level of our staff that's really bothering me. We have a great staff. We have good longevity. But everybody feels like I do. We have just been doing this so long, and we just keep getting beat down at every corner that we're at that we need to do something different. We have a higher than average acuity rate. We have an increased risk for litigation. We have poor patient compliance and inability to follow them correctly, and a care avoidance due to cost. So we can no longer support the wheel that we run on. This is just one of the data points we look at, but the main reason is I know it's really busy and I apologize. But this is really looking at where we get our payments from. And the big red line on top is the patient fee-for-service business. We're able to attract a decent fee-for-service, and we have decent revenue from it. As you can see by the quarter, we're anywhere between $300,000 and $400,000 in revenue. That's a concern switching to DPC, and those are the projections that I'm currently working on, is what percentage of that population is going to convert to DPC. That population is utilizing us how often now? How often will they use us in DPC? So I do more of the data analytics and the projections because that's part of my job. And it intrigues me to see how many will we convert. That is not my target market. That's my bread and butter for my main practice. When we open DPC, we're going to exclusively keep them separate. So we will run a hybrid model, but it will be a completely separate hybrid model. So I will be able to do data analytics on the fee for service, the conversion rate, and what our outcomes are in DPC in the same marketplace, completely exclusive of each other. So we also track the smaller yellow line in the middle is the cost of business for patients in cash that we get for them for their insurance co-payments, co-insurance, and deductible amounts. So it's yet another line of cash because we do collect at time of service, but it's just a good number to keep an eye on, and it'll be interesting to see where all this goes. So our reality today is that we run the business of medicine for no payment at all. We operationalize our insurance contracts, and we staff them for free. So we continuously and nonstop educate on design, plan coverage, prior authorizations, studies, referrals, peer-to-peer reviews, and we get paid nothing for any of it, and that's where most of our aggravation comes from. So I'm here to talk about how this evolves within a practice. How do you make this move in your practice? And for us, it was looking at the things that aggravate our staff and our providers the most and seeing how well DPC fits into that solution for our practice. So I did this from many different areas, but I did spend about 2 weeks doing a time study on how much of the time in a day is devoted to insurance that we don't get reimbursed for. Because it really has to be like an aha event to get providers and staff to this level of understanding what it's like to not be in the insurance market. It's really hard for people who have been so deeply seated in this for so long to come around. I do a lot of volunteer work in Cuba, and I have to say it's kind of like a communism kind of behavior. You've been beat down for so long that you can't imagine anything different, and when someone talks about it, you don't really even know how to handle that. So I looked at it from many different areas, not just financial, but I did become a watcher within my current environments. And there are two things that really stood out to me. I have a drug screening department that is billed direct to employers net 30-day. So no contracts, no insurance, no anything. So I spent a fair amount of time in their department talking to them. Their satisfaction in their job is higher than my front desk receptionist, but yet they see equal volumes of patients and they run independently with little to no supervision. They get the highest customer service ratings from the employer groups, and I realized it's because they simply don't deal with insurance a lot at all. They're dealing directly with the employers. They're providing a service. It's a customer service area. They have their own schedule. They treat their own patients. They see them timely and on time. and they report directly to me. And so there's no middle people, there's no insurance, there's no explaining details. It's a very simple procedure. And I thought, well, isn't DPC a really simple procedure too? No insurance, report directly to the patient, they pay their bill. It's kind of the same thing. But then you look at my front desk girl who gets hollered at all day long, has to explain everybody their benefits every time they walk in. My checkout girl who gets beat up because no one wanted to have the conversation with the patient about the deductible, and that the stress test goes on the deductible, not the copayment. And I go through front desk people. I hire women my age for my front desk because I think they have incredible customer service. They don't last 90 days because they can't multifunction. So the stress level is too high there for incredible customer service. It's really somebody who's very tech savvy, who's very quick on their feet and can do multiple things at once that ends up being our front desk person. Not the woman who'd like to get to know them by name, and know their children when they walk in. Not necessarily what I want at my front desk. So we interviewed staff. We started to document negative interactions. I went back and pulled exit interviews with staff that had left just to refresh my memory about why they left. And most of it was stress, customer dissatisfaction, getting things taken out on them that they didn't have control over. Most of that related to insurables. So what I found is 32% of any given day in my 9-doctor practice was devoted to providing insurance support for which we didn't get paid for. So that was an eye-opener. If I could reduce my staffing by 32% just by getting rid of insurance, what else could we do? So we decided to call it pissed. We're pissed. So that's what we are. So that is our little, our fun thing that we are working on. So we're on the pissed project now. So that's my ICD-10 diagnosis, and I really don't care. It's our deeply ingrained way of doing things and has made an incredibly intelligent group of amazing providers and staff having a hard time wrapping their head about anything different. So the idea and freedom in treating patients for the best of the patient without asking for permission is just something that we're simply not used to. So we are working to go forward and get out of this, but we remain pissed at this moment until September 1st. So these are some of the decks that I just shared with my staff when we were talking about progressing. And I really think that this is about a culture that needs to be explored. I am the past president of MGMA for the state of Florida. I just got done my 1-year tenure in October, and I have to say that I was exceedingly dismayed on a national, they always send us these stat questions to our phones, and on May 15th, they sent out a stat, what's your idea kind of thing, and it was related to DPC. So MGMA is the largest governing body for people that do what I do, run practices for a living. And luckily, when I was in San Francisco 2 years ago, I did meet Dr. Flanagan, and that's what started this journey. And I was really there to find a different way of doing medicine and really struggling whether I was going to stay in this revenue area or if I was just going to leave medicine completely. And after meeting him and taking that survey on May 15th, I was really dismayed that out of 1,435 members of National MGMA, only 26% of us knew what DPC was. So it's not just the doctors, it's not just your staff, it's getting that word out across the board, because you can't tell me that they don't feel the same way that I do. Whether they're in academics or they're in private, there's opportunity for everybody in this area. So I looked at what the biggest concerns were in my practice for dissatisfaction, and I tried to see if there was a direct correlation that DPC could offer a solution to. So I told them to think about it in a completely different way. You don't buy car insurance for your gas, otherwise you need prior approval to leave town. So why are you buying insurance for direct primary care when it's affordable and accessible? So it was really about educating them about peeling back the layers and really getting to the core of what does this mean for change for our practice. So we went through this slowly, and needless to say, my older staff about had a heart attack and wanted to know how we were going to get paid, how are they going to get paid, how are their bonus calculations going to be computed now, and what does that mean to them long term. So we have made the commitment to move. We have made the structural decision that we're going to segregate it and not do a complete hybrid practice. And that basically fell back to me, and my crux of that is that we have an engine that's running upstairs that is still generating revenue. It's not an easy thing to exit a 30-year practice with 10 providers, so it needs to be a strategic exit that's measurable for outcomes and for financial viability of the larger group of people. I'm responsible for almost 90 people's lives and their income, and I have to make good decisions for the right reason, and I know in my heart that this is right, but it is not right for me to cut the cord and jump. We have too much well-vested occupational medicine, which we'll never give up, that will always work very well with DPC and put us in a leader in our community for DPC medicine. It also is a cash-based, net 30-day, most of it, billable, direct-to-employer with no insurance. It's the perfect match. So as you're looking at your DPC models, when you get to that table with your employers, it's the perfect opportunity to move into other things. You can do DOT exams. It's what, a 2-hour class. Do it, take it, charge $125 for them. Do employment physicals and wellness and prevention. You're going to help them identify things that they may not want to hire or risks they may not want to take. It's time that you guys stop taking a back seat to carriers and start sitting at the table. It's your brain that they're looking for. It's your education and your commitment to patient care that's going to help them have better employees, have better outcomes, and have longer lasting employees. So it's not the carriers that do that. The carriers are in there to collect the monthly money and walk away. We're the ones that are relationship people, and you need to start putting that in the forefront of your thought process, because occupational medicine can help you complement your income stream and continue to increase your ability to grow it even further. So for us, we are the largest group, and we are completely privately owned. I have one owner, so my life is so much easier than other people. I don't have a board. I don't have partners. It's my rogue MBA and I who have been in this partnership together forever. We trust each other. We have a great relationship. He's the great doctor, and I run the business. So we can move things quickly. We are in Naples. Our fees are higher than the average fees. We're an exclusively rich community. I did the test market on what we thought the market could bear, and I figured I would share this. No one seems to talk about it lately in this conference, but I just thought, hey, we share information in DPC, so let's not be competitive. We broke it out by age, and with the help of Hint, who has some great data mining on all of everybody who's already participated, my revenue actually is going to be higher than my initial projections, because their data shows that I will have more people in older groups joining me, so more of the 30 and up to 50 age, where I was thinking I was going to pick up more of the servers, because I live in Southwest Florida. I live on the beach. So I figured I'd pick up more restaurants, hotels, and things like that. Their data suggests that people in the older age group are going to be a more lucrative group to market to, because they're looking for an alternative, looking for better care. They have the money, and they're willing to put it where it counts. So this is where we are. This is what we've decided to cover with our fee schedule. Our big beast upstairs has a moderately complex lab, digital radiology, all those wonderful ancillary products we need to add on to make revenue when we have to do insurables. We're keeping that separate from our DPC. Although after yesterday, I'm considering I don't really want to do biometrics, because insurances do biometrics, but I see value to that data point, so I'm still thinking about that. I think that the data we collect is going to be amazingly helpful for us in the future. So I did the math. I did my own projections based on demographics. I broke it out, how many patients I thought. We're going to do this, that, or the other, just for you-know-what and giggles. And we will be charging for x-rays outside of vaccines. We're just going to be transparent, cost plus a percentage. We're going to let them know where the cost comes from, the vaccine company, not the provider. So we plan on being completely transparent through invoice pricing on everything we do. So basic bottom line is it took 5,000 patient visits with insurance to earn $599,000 in a quarter. It took 500 patients to earn $658 in a year with DPC, all prepaid, no insurance, no collections, no lost revenue sources. Do most patients come in 10 times a year? No. How many visits do we really need an average person to do great prevention and treatment? Give me 6 weeks and I'll feed that back to you. And based on our current model, and then, what would it be like to not have prior approvals and just see people because you can? So that is our story of where we are. We will be going live on September 1st, and we are really excited to join this movement. Thank you.